Let's talk about the care plan for lactic acidosis now. So, as mentioned in the previous slide, the definition of lactic acidosis occurs when lactic acid builds up in the body faster than it can be metabolized, leading to a decrease in the blood's pH. It is often also associated with conditions causing tissue hypoxia, impaired metabolism, or mitochondrial dysfunction. So let's do a step-by-step guide on how we can care for someone with lactic acidosis. So step one starts with the assessment and diagnosis. Starting with the patient's history, we need to assess for underlying conditions. This can include sepsis, hypoperfusion, diabetes, malignancy, or drug toxin exposure. We need to inquire about the medications they are using to see if that has an effect on the blood's pH, like metformin or antiretrovirals, and see if there's any alcohol abuse present in the patient as well. We're going to do a physical exam for the patient, evaluate for signs of hyperperfusion. This could be like cold extremities, delayed capillary refill, or hypotension. We want to look for respiratory compensation as well, like Kussmaul breathing due to metabolic acidosis. The next step would be diagnostic testing. We want to do an ABG to confirm the metabolic acidosis by seeing that there is a low pH or low bicarb. We want to assess the lactate levels. If it's elevated, greater than 2, that means it's severe. And we also want to look at the anion gap levels. If they're elevated, that indicates accumulation of organic acids. We could do a CBC, complete blood count, to check for infection or anemia. We could do renal function and electrolytes, assess that to identify if there's any organ dysfunction present. We could do imaging to rule out hypoxia-related conditions like pulmonary embolism or ischemia. Step 2 would be the pathophysiology and goals of the treatment. So for pathophysiology, there is 1, tissue hypoxia, which is when there's an oxygen deficiency leading to anaerobic metabolism and excess lactate production. Number 2 is impaired clearance, like liver and kidneys fail to metabolize lactate efficiently. Number 3 is mitochondrial dysfunction, like inhibition of oxidative phosphorylation, resulting in lactic buildup. The goals would be to restore tissue perfusion and oxygenation, correct the metabolic acidosis, and address the underlying cause. Step 3 would be our intervention plan. So number 1, we want immediate stabilization. So we want to check their airway and breathing by administering high flow oxygen or initiate mechanical ventilation if respiratory compensation is inadequate. We're going to correct the hypoxemia to enhance aerobic metabolism. We're also going to check their circulation, initiate their fluid resuscitation with isotonic crystalloids like 0.9% NaCl or Ringer's lactate to improve the perfusion. We want to use vasopressors if hypotension persists despite giving the fluids. Number 2 would be correcting that metabolic acidosis like I talked about. We want to do possibly sodium bicarb therapy. This can be kind of controversial, but you can use it cautiously for pHs less than 7.0 or life-threatening acidemia, as it may worsen intracellular acidosis and increase CO2. We could check on this by doing an ABG frequently to monitor any underlying changes. Number 3 would be to manage the underlying cause. If it's sepsis, we want to administer broad spectrum antibiotics after our blood culture and follow the sepsis protocol. If it's a diabetic ketoacidosis, we want to provide insulin therapy and correct hyperglycemia and electrolyte imbalance. If it's caused by renal failure, we may consider dialysis to remove lactate and correct acidemia. Let's do, or if it's a drug toxin induced, we can discontinue offending agents like metformin, salicylates, administer antidotes if applicable. Number 4 would be to monitor electrolyte imbalances such as potassium and calcium. Hypokalemia may occur during the correction, so we can supplement carefully to avoid arrhythmias. Calcium, we monitor for hypocalcemia if bicarb therapy is used. Next is step 4, monitoring and reassessment. We need to recheck the lactate levels every 4 to 6 hours just to make sure. We want to monitor ABG, electrolytes, renal function, and hemodynamic parameters regularly. Also, we need to observe for signs of organ failure, like worsening mental status, decreased urine output can be some examples for us to look into. Step 5 would be patient education and long-term management. We want to educate on managing underlying chronic conditions, like if the patient has diabetes, liver disease, just educate them on what to do. We want to avoid their triggers. If the patient has any like alcohol, medications like metformin and renal impairment as well. We want to ensure follow-up with specialists like an endocrinologist, nephrologist, or interventivist based on the etiology of the issue. An example for a case correlation that can be used is for septic shock-induced lactic acidosis patients. The tissue hypoxia results in anaerobic glycolysis. Fluids and vasopressors can restore perfusion. Antibiotics will address this infection, and lactate clearance is monitored to guide the therapy. This structure care plan is perfect for this patient.